introduce. Welcome everyone. So we are pleased to have Dr. Amr Mohamed with us. He was a long-term fellow in pediatric ophthalmology in Strabismus in Sankara Eye Hospital, Bangalore, India, and he is currently a consultant in pediatric ophthalmology at Noor Al Yemen Eye Center, Yemen, Sana. And as you all know, he is looking after the MVUPGO Pediatric Ophthalmology and Strabismus group, and we are very lucky to have him. And he'll be discussing examination technique in Strabismus, which is very important for FRCS. Dr. Amar, please start.
Thank you so much. Okay, so I will start with the outline of the presentation. So I will start with the strabismus patient examination in general, which will include the inspection and the sensory evaluation of strabismus. It's not very important for the practical part of the exam, the clinical part, but it's important in general. Also, you might be asked about in the Viva part. Then we will cover the main parts, which is the cover test, motility test, and nystagmus examination. I tried to make the presentation as interactive as possible, so I will need some volunteers to help us in solving some of the cases. So starting with strabismus patient examination, so the preliminary evaluation includes the history, which is very important in diagnosing any patient with strabismus, then the visual acuity, and if the patient is wearing glasses or not. Also, anomalous head position, nystagmus, facial asymmetry, ptosis, palpebral fissure changes, and facial dysmorphic features. And to reach diagnosis in a patient with strabismus, it's like a puzzle. So you need to collect as much as possible puzzle pieces to reach the full picture and to reach the proper diagnosis. So a lot of data you can get without touching your patient. So with inspection, you can figure out if there is any dysmorphic features, if there is any facial asymmetry, abnormal head posture, or any abnormal visual behavior. Inspection of the head position, abnormal head position or anomalous head position in any state in which head is not held upright. And we have three types of anomalous head position, whether chin up or chin down, face turn to the right or left, or head tilt to the left or right. Causes of abnormal head posture, we have ocular and non-ocular causes. Ocular causes, whether paralytic strabismus, like sixth nerve palsy, usually the patient will have face turn toward the same side of the paresis. For example, if the patient is having right sixth nerve palsy, you will have face turn to the right. We have also third nerve palsy. The patient will have face turn to the opposite side. Also, for fourth nerve palsy, usually patient will have head tilt. Nystagmus also, if the patient is having null position in one of the head tilt or face turn or chin up or chin down, he will adopt that head position to dampen the nystagmus and to have better vision. A or V pattern strabismus as well, and restrictive strabismus, whether Duane retraction syndrome or congenital fibrosis of extraocular muscles, which usually will be associated with ptosis, and the patient may adopt chin elevation. We have also non-ocular causes like contracture, fibrosis of sternocleidomastoid, and unilateral hearing loss, and psychogenic torticollis. So that is example of left head tilt and the chin elevation. So also the facial symmetry is very important. So you might have hemifacial hypoplasia like this patient with congenital fourth cranial nerve palsy. You may have something called plagiocephaly. So there will be depression in part of the skull, and plagiocephaly usually associated with oblique dysfunction, especially superior oblique overaction. Also, dysmorphic features is very important because there are a lot of associations between some of the syndromes and strabismus, like Cruzen syndrome. You might have V-pattern exotropia, Down syndrome associated with many types of strabismus, whether especially esotropia. Also, the inspection to observe the width and direction of lid fissure, which may give a clue to the presence of pseudostrabismus. Look for the features of epicanthic folds, telecanthus, hypertelorism, negative or positive angle kappa. Also, the mongoloid up-slanted palpebral fissure and the anti-mongoloid down slanted fissure. All these can give an impression of A or V pattern strabismus simulating pseudo-inferior oblique overaction or superior overaction or underaction. You can see in this picture, because of the epicanthic folds, there is pseudo-esotropia. Although the Hirschberg is central, the patient is having central light reflex, and that is pseudo-esotropia. Here we have the distance between the two canthi is large, and although the Hirschberg test is central light reflex, but it gives the picture of exotropia. So that is a pseudo-exotropia. So you need to like inspect well and take a note for such conditions with telecanthus, hypertelorism, or epicanthic folds that may simulate strabismus condition like esotropia or exotropia. Coming to the sensory evaluation, I will not go deep in this. I will just go very quickly to save the time. So in the grades of binocular vision, we have 3 grades: simultaneous perception, fusion, and stereopsis, and we can measure or test the 3 grades of binocular vision through synoptophore. So sensory evaluation, we have 2 main parts: the stereopsis and the word for the test. Stereopsis, we have many tests like Titmus test, we have Lang test, Frisbee. We have many tests to test the stereopsis. So one of the most popular ones are the Titmus fly test. What you need to know about it, that usually we use polarized glasses. The book should be held 30 to 40 centimeter away from the patient, and he need to elicit which circle is coming forward, or it is in 3D. And each circle has a number of seconds of arc, and if the patient answers all, he will have higher degree of stereo acuity. Word for the test, we usually do it for patients who has no stereopsis or they have manifest strabismus. So we will get to know what is the fusional state of the patient. So word for the test, usually we use that red-green glasses, red over right, RR, red over right, and green over the left. And we use that torch. Word for the test usually done at near, intermediate, and distance. So at 30 to 40 centimeter away from the patient, then 1 meter, then 3 or 6 meters. When we are doing the word for the test, we have the interpretation. So anyone can help me in eliciting what we can get in word for the test, the results?
In words for test, we will show the 4 stops: 1 right, 2 green, and 1 white. If the patient sees all 3 this normally, so patient has a normal DSV. If it is a patient seeing 2 red and 3 green, so mean patient have a diplopia.
Okay.
Yes, and if a
patient is has tropia and still he gets to see all 4 points, then he has harmonious type of ARC.
Okay. There is one more thing that you didn't cover, the suppression.
Suppression, yeah.
Yes.
So
If
if
it's
the
the
patient is having right eye suppression, what he will see?
in the red eye suppression, he will see only the red spots, two red.
So if
Green spots.
there is right eye suppression, he will see 3 green lights.
Green spots, sorry, 3 green spots. And if it's there's a left eye suppression, he will see the red spots.
Yes, he will see only 2 red spots. And there is one more condition. If the patient is having exotropia with alternate suppression, he will see the 5 dots, but he will not see the 5 at the same time. He will tell you, I'm seeing 3, 2, 3, 2. So if that happened, then the patient is having alternate suppression. So when the patient is describing that he is seeing 5 dots, you need to ask him specifically, do you see the 5 points or the 5 dots together, or you are seeing 3, then you are seeing 2? If he is not seeing them together, so this is alternate suppression, which is common in exotropia patients. If he is seeing the 5 dots together, so that is diplopia. Then also we can differentiate whether it is crossed diplopia or uncrossed diplopia. So in uncrossed diplopia, what the patient will see? Uncrossed. Anybody? Okay, so in uncrossed diplopia, the patient will see the two right dots on the right side and 3 green dots on the left side. If the patient is having uncrossed diplopia, if the patient is having crossed diplopia, then he will see 3 green dots on the right and 2 red dots on the left. Okay? Am I clear so far?
Sir, what you said, no, that right eye red and left eye green.
Yes.
If I am not wrong, in Kansky, I read reverse.
Usually that is the usual way. You can do it ulta, but then all the interpretation will be, the opposite. But the
Yes.
usual way of doing word for the test to put the red glass over the right eye. And it is RR, so it is easily to remember. But you can do it on the other side. You can put the right over the left, but then all the interpretation will be different. For example, the right suppression will give you 2 red lights. The left suppression will give you 3 green lights,
Yes,
etc.
yes, sir. Yes,
So
sir.
that interpretation only if you are putting the right glass over the right eye, left green glass over the left eye. Okay?
Okay.
Sir, I have
Good.
one doubt. If a patient
Yes.
has 4 lights in a normal patient without squint and in a squint patient, so whether we write it as a BSV in a squint case or we should write it as an ARC?
If the patient is having manifest deviation, so that is ARC.
Yeah. Only in straight eyes we can see BSV, right?
Yes, definitely. Thank you. Okay. Yes, here the uncrossed and crossed, that is from the patient perspective. So this is the right side, this is the left side, okay? Okay, coming to the motor evaluation. So motor evaluation, we have the light reflex test, Hirschberg test, and the Kremesky test. We have the ocular motility. We have motor evaluation, including the cover test. Then we have alternate prism cover test. So if you get a patient with strabismus in the examination, you might have 2 scenarios. Whether the examiner will tell you test the extraocular motility, or he will tell you do the cover test. So it is advisable if the examiner told you do the extraocular motility to tell the examiner, I would like to do cover test first. Can I do it or not? So the order of the examination for FRCS, they prefer to do the cover test first, then the extraocular motility. So if the examiner told you do the extraocular motility, then you can tell him, I would like to do the cover test in first. Then he will have 2 options, whether he will tell you, okay, go ahead, do the cover test in the beginning, or he will tell you, no, just do the ocular motility test. Okay. So for the cover, before doing the cover test, you will do the very simple Hirschberg test. Hirschberg test will give you an idea about the position of the eye. It is like only a starting point before starting your examination. So if the patient is ortho, you will find the light reflex central in both eyes. If the patient is having esotropia, then you will find the light reflex temporal. And then there is angle estimation. So if the light reflects in the pupillary border, how many prism diopter? Anyone can help me?
15 prism diopter.
No,
No.
15
30
degree, 30 prism diopter. There will be a 15 degree at the
degrees.
margin of the pupil,
15,
and it will be
15 degree.
30,
15 degree.
yeah, 15 degree and 30 prism diopter.
Yes, that is one of the most common things that people usually, will miss. Degrees, 1 degree approximately around 2 prism diopter. So for the degrees, if it is on the pupillary border, that is 15 degrees or 30 prism diopter. If it is midway, then that is 30 degrees or 60 prism diopter. If it is on the limbus, then that is 45 degrees or 90 prism diopter. Okay. Okay. So before doing cover and cover test, you need to ask a very important question. What is that question? Anyone can help me? You need to tell the examiner, I would like to check this thing before doing
Vision,
cover.
vision of a patient.
Exactly, exactly. That is a very important point. If you did not mention it, then you are in a big trouble, because one of the prerequisites to do the cover test that the patient is having good vision in both eyes, at least 636. Okay. So you need to ask the examiner, what is the visual acuity of this patient? Then only if the examiner told you, okay, the patient is having 6/6 vision in both eyes with glasses, or the patient is having good vision, you can go ahead with cover test, then you can do it. Otherwise, if the examiner told you the patient is having light perception, vision in one of the eyes, or hand motion, or counting finger close to face, or counting finger 1 meters, then you will tell the examiner, I can do only Hirschberg test and Kremsky test to estimate the angle of deviation. You cannot do cover, uncover, alternate prism cover test. All these tests, um, you cannot do it if the patient is having one eye with poor vision. Am I clear so far?
Yes, sir.
Yes,
So
sir.
Okay.
basically less than 636, or it's we can do on a 660. Less than 636, we cannot do the cover and uncover. For
You
that,
can
we
do
have
also
to the
with 660, but the thing is when you are putting the prism over the eye, that again will, decrease the visual acuity. So, there is no cut point, but at least the patient, will see 660 or 636. Then only you can do proper cover test. Then you can go ahead with other tests like alternate prism cover test, and you should use the target that matches the visual acuity of the patient. For example, if the patient is seeing only 660, you cannot use 636 or 615, because he will not see
okay.
it. And
Okay,
also,
thank you.
when you start doing the cover test at near and at distance, at near you must have fixation target. You cannot use light. Light is not an accommodative target, and you cannot use light. You have to have a fixation ruler with fixation target. And before starting, you close the left eye, ask the patient, can you see? Then close the right eye and ask the patient, can you see? Then at distance again, if there is a visual acuity chart or screen, then you will ask the patient again before doing the test, can you see with the right eye? Can you see with the left eye? Then only you can proceed. Okay? That is a really important point. So we have cover test and uncover test and alternate cover test and alternate prism cover test. Okay, so cover test, done for manifest squint. So for example, if the patient is having right esotropia, so I will do cover for the left eye and see whether the right eye will move or not. And in that case, the eye will move from inward to outward. Okay. Uncover test done for latent squint. In the same example, if the patient is having right esotropia and I did the cover test over the left eye, the right eye moved outward, then I will do uncover for the left eye and see if there is any movement in the left eye or not to check for the latent squint. Then the alternate cover test, usually you will see both tropias plus phorias. So as I mentioned, prerequisites for doing the cover and cover test are central fixation in both eyes, reasonably good vision in both eyes, better than 636, no gross ocular movement limitations, because again, in a patient with, for example, third nerve palsy, complete third nerve palsy, it is extremely difficult, to estimate the angle of deviation because eye is not moving at all. There is no adduction, no elevation, no depression. So even if you put any prism over the same eye or on the other eye, there will be no proper movement. Alternate prism cover test is the gold standard in measuring deviations. We should do it at near and at distance with glasses. Patient should wear the glasses. And also we should do it without glasses, especially in cases of accommodative esotropia. Also in up gaze, down gaze, right gaze, left gaze. Why? Why that is important? Up gaze, down gaze. Why?
If there is any pattern.
Yes, to check for the patterns. If the patient is having A pattern, V pattern, and right gaze, left gaze, why it is important?
To see in which case it is more, so that
Okay. Yes, that is one thing in restrictive cases. If the patient is having comitant strabismus, then it is also important in some cases there might be something called lateral incompetence. In patient with exotropia especially, you might have something called lateral incompetence. The angle of deviation in right gaze, left gaze might be less than the angle in the primary position. And if the patient is having vertical deviation, then you need also to measure the angle of deviation in the right tilt and left head tilt. Okay. So before starting, if the examiner told you, okay, please do cover test for this patient. So you will start by the following. I'd like to know the visual acuity of the patient. Okay, he will tell you it is 6.6, for example, with glasses. Then check the glasses. Check the glasses, whether it is myopic glasses, hyperopic glasses, high myopia, high hypermetropia. That again will help you and will give you a clue about the case. Then you will tell the examiner, I would like to measure the deviation at near and at distance with glasses, without glasses, up gaze, down gaze, right gaze, left gaze, right and left head tilt if there is any vertical deviation. So if you say so, you will give the examiner impression that you know well what you need to do. In most cases, because of the time constraints, examiner will not let you do all these things, but if you say it, then the examiner will know that you know exactly how to evaluate a patient with strabismus. So that is a
Dr. Amr, sorry, I have a question here.
Yes.
Is there a protocol for whether you should do cover uncover for near first or for distance first and with glasses first or without glasses first?
There is no clear protocol, but usually in any patient with strabismus, you need first to correct the refractive error. So if the patient is having glasses, you will take the measurements with the glasses, with the refractive correction and with the best corrected visual acuity. So usually the most important is taking the measurements with glasses. In a case of esotropia or a patient with high plus glasses, you might need to do it without glasses just to diagnose a patient with fully refractive accommodative esotropia. Then usually we start at near in the beginning, then doing at
Right.
distance. At near, you need only to do the primary position. At near, you need only to do the primary position measurement. At distance, you do the rest of the measurements. You got this point?
Right.
So at near, only primary position is enough. At distance, you need to do primary position, up gaze, down gaze, right gaze, left gaze. And if there is any vertical deviation, then you need to do the third step of the three-step test and do the right and left head tilt measurement to know which cyclovertical muscle is affected. Okay?
Thank you.
So
Sir,
that is,
sir, one thing I want
yes,
to ask, in the vertical deviation, you told the part three step, whether we will do the initial, what do you tell, like near, distant, up, down, side, and then tilt?
yes, you know, when you are doing the primary position measurement only, you will get to know whether the patient is having horizontal deviation only, vertical deviation only, or is having mixed vertical and horizontal deviation. So if
Yes,
the
yes,
patient is having only horizontal deviation, you don't need to do right and left head tilt.
yes, yes.
If the patient is having vertical, then you need to complete the examination and do the right and left head tilt measurements. Okay.
Okay.
So that is just an example of one of a chart of one of my patients. So first, I usually comment on the fixation pattern. So in this example, patient is having central steady unmaintained fixation in the right eye, central steady maintained fixation in the left eye. Then I draw those two circles, right eye, left eye. 0, 0, 0 means full extraocular motility. Here that patient is having inferior oblique overaction +3 in the right eye with -2 superior oblique underaction. Then in the primary position, the patient is having exotropia 45 prism diopter with right hypertropia 14 prism diopter in primary position at distance, in up gaze 50, in down gaze 30 to 35, then in left gaze and right gaze measurements, then right head tilt, left head tilt, and near deviation. Only as I mentioned, primary position is enough. So that is just an example on how to do
So,
the measure- yes.
yes. Dr. Amar, sorry for interrupting. When we're telling about the deviation, should we tell in prism diopters or degrees? If a
Prism
patient
diopter.
is there with
If you
prism
are measuring,
diopters.
yes, if you are measuring because the prism, you know, you are using is only with prism diopter. So degrees only important in Hirschberg, and also in Hirschberg you can say with the estimation with prism diopter. It is okay.
Okay.
Okay. So summary of cover test. We have cover test, uncover test, alternate cover test, then prism cover test, alternate prism cover test, and we have something called prism undercover test. Anyone know about it? Prism undercover test?
Yes, that is for measuring the dissociated vertical deviation.
Yes. So usually, for example, if I am having patient with left DVD,
Mm.
and
Yep.
I want to know the estimation, whether it is a small DVD, something within 10 prism diopter, whether it is moderate DVD, something around 20, or whether it is large DVD, something beyond 30 prism diopter. Then I put the cover and I put the prism behind the cover, and then I remove the cover and see whether the eye is still moving or not. So that is only for DVD angle estimation. Why it is important? Because, for example, if you are doing superior rectus recession for a patient with DVD, then you need to know whether it is small DVD, moderate DVD, or large DVD to know whether you need to do 6 millimeter superior rectus recession or 8 or 10. Okay. So now I will come to some of the videos that will help us to know more about the examination. So
Uh,
this one,
Sir,
oh,
I want to
can
ask
you
one
hear
thing.
me?
Hello, sir.
Hello?
Feet away. Cover the left eye and watch for a movement of the uncovered eye. Repeat this step a few times. Then do exactly the same thing in covering the right eye. If no movement occurs in the uncovered eye, the eyes are aligned. Here is a patient with esotropia. The left eye is deviated inward. As the fixating right eye is covered, the left eye moves outward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye. Here is a patient with exotropia. The left eye is with esotropia. The left eye is deviated inward. As the fixating right eye is covered, the left eye moves outward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye. Outward. As the fixating right eye.
So here you can see the patient with left exotropia, he covered the right eye. So the left eye moved. Okay, then patient again maintain fixation with the right eye and the left eye. Here covering the left eye, there is no movement in the right eye. So that is left manifest exotropia. Here a patient with hypertropia in the left eye. When he is covering the right eye, the eye will move downward. When covering the left eye, there is no movement in the right eye. So that is left manifest hypertropia. Okay. Here, alternate cover test. So when you are doing the alternate cover test, do not move very fast. You need to leave the cover at least on the eye for at least 1 or 2 seconds, and you need to check with the patient if he can see the target. For example, I'm covering the left eye. I will ask the patient, can you see the target with the right eye? Okay, then you will move, the movement between the two eyes should be fast. So the patient will be kept dissociated, but keeping the cover over each eye for 1 to 2 seconds. In patients with DVD, you need to leave the cover for a longer time. Okay, also in patients with very large deviations, again, you need to leave the cover for a longer time because patient will need more time to fixate. Okay, so 1, 2, 1, 2, 1, 2, 1, 2, like this. Okay. Okay, so that is a short video from Shankar Academy of Vision. So here are the things that you need to have for strabismus evaluation. You need the prism, whether the loose prism or the prism bar, and the accommodative target is extremely important. Without accommodative target at near and at distance, the chart, you cannot do alternate prism cover test. And the occluder, whether the normal occluder, the opaque, or the Spillman occluder. Spillman occluder has one advantage in patients with DVD. You will get to elicit the DVD easily. Okay. Can you hear me? Hello?
Yes, we can hear you,
Yes,
doctor.
yes,
Okay.
yes.
Okay, thank you so much. Here for the extraocular motility, that's just the elicit of the extraocular muscles. So here we have left medial rectus, right lateral rectus, right superior rectus, left inferior oblique, right inferior rectus, left superior oblique. Here we have right inferior oblique, left superior rectus, right medial rectus, left lateral rectus, and right superior oblique, left inferior rectus. In pure elevation and pure depression, we have two muscles responsible for the movement, not only the recti. Okay. Okay, here we will come to the other extraocular motility examination. Just 1 second. Yes, here is the charting. You have many options, whether to do the circles or the H or the cross. Okay. Coming to the Kremesky test. So Kremesky is a light reflex test using the prism, and it is usually used if the patient is having one non-seeing eye. So you cannot do alternate prism cover test, then you go for Kremesky test. For example, in this patient, he's having esotropia. So you will put the base out prism over the seeing eye or the fixating eye, and the deviated eye will start moving. When that eye will, the light reflex will be central, that is the angle of deviation of the patient. You can also do the Kremesky test over the deviated eye till the light reflex test is central. So you can do it over the seeing eye or the non-seeing eye, the deviated eye. Okay. It is much easier to put it over the seeing eye because the light reflex over the deviated eye will be more visible and more clear. When you are do it over the deviated eye, then you need to see the reflex through the prism. And if it is large prism, then it would be a bit difficult. Okay. So we have Kremesky test for estimation of angle of deviation in patient with one non-seeing eye. So that is an example for a patient with right hypotropia, So I put base down prism over the left eye till the reflex became central. Here the patient also is having a bit of exotropia in addition to the hypotropia, but the main deviation was the hypotropia. So remember also how to hold the prism. It is extremely important, and you should not be hesitant during the examination. Okay, because if you start to be hesitant when the examiner told you to examine or to measure the angle of deviation and you started holding the prism in a wrong way, that is one of the fatal mistakes, and it will give the examiner indication that you did not have enough practice for this. So my advice,
Sorry,
yes,
Dr. Ahmad, in this case, there is right hypotropia. So
yes,
in the left eye, you're holding the prism with the base down, apex up.
yes,
Mhm.
yes. In
Why
vertical
is that?
deviation, because of the Hering's law, in vertical deviation, if you are having, for example, right hypotropia, the same thing, and you put the prism over the left eye, so that is the hypertropic eye. So you need to put the base down. But if I
Right.
put the prism over the right eye, then I will put it base up. Okay.
Yes. Okay.
So in
Okay.
vertical
Thank you.
deviation, you need to change it. In ESO and EXO, it is the same. In ESO, always the base is out. In EXO, always the base is in. Okay.
Exo in, yes.
Yes. Exotropia base in, esotropia base out. In hypertropia, if you are putting the prism over the hypertropic eye, then you need to put the base down.
Base down. Yes.
Putting the prism over the hypotropic eye, then you put the base up. Okay?
Right.
Okay. So after finishing the cover test, cover, uncover, alternate prism cover, you will go for extraocular motility examination. So that is only the chart. You need to know this by heart. So when you are doing the extraocular motility, you know which muscle is overacting or underacting. So it's extremely important to know this by heart. We have 3 types of extraocular motility. Anyone can help us in this?
Version,
Yeah.
if there's any abnormality, then duction and
Yes.
versions.
Yes, exactly. So we have versions, that is binocular examination. If there is any limitation in versions, then we go for ductions. to confirm the limitation or the restriction, then we can go for versions and versions. The practical use for it mainly for convergence. Divergence, usually we don't measure it, but it is also there, the divergence amplitude. So
लेकिन मैं यही आपको बता रहा हूँ ना कि अगर तो सेम डे ट्रीटमेंट होता है तो हम लोग उसका चार्ज नहीं करते, और अगर ना हो, सेम डे ना हो, तो हम लोग चार्ज करते हैं। यही तो मसला मैं आपको बता रहा हूँ कि वो फिर बेकार में आ जाएगा कि भी जैसे मंडे में ट्रीटमेंट होना है तो कल तो फिर बिना वजह 4,000 का चार्ज हो, लेकिन बाकी देखिए जैसे आप कहते हैं तो कल भेजना तो भेजना मेरे पास 3 बजे तक।
can you please mute? Hello?
Yes, sir. Continue.
Okay. So, as we mentioned, if there is limitation of extraocular motility during the vergence, so we go ahead for ductions to quantify how much limitation of ductions is there. So, for example, in this patient in the right eye, we close the left eye, we cover the left eye, we are checking the right eye. So if you cannot see any white part in the during the patient is doing abduction, there is no white here, then that is normal. If you can see part like 25% of the movement is not there, then that is -1, 50% -2, 75% -3. If the eye is not crossing the midline, then this is -4 limitation of abduction in this example. That we already talked about it. Now I will, yes, we'll come to that important video. So here, as I mentioned, if the examiner told you do the extraocular motility, then you will ask, I would like to check if the patient can see. Then he will tell you about the visual acuity. Then you can ask the examiner, would you like me to do cover uncover first? Then observe, as in cover uncover, 9 gaze, use the target. Then you will go for divergence. Then if there is any limitation, you will go for ductions. And during doing the extraocular motility, you will ask the patient, can you see the target? You see it as 1 or 2. If 2, ask about the relation between them, whether the two targets are side by side or up and down. And follow this, you will tell the patient, follow this target and tell me if it doubled any time. Move slowly, full arm, return to primary position at each time. I will show you illustration of this by Dr. Mohamed al-Naggar. So he started with the levo version, then coming again to the primary position, then go levo elevation, coming again to the primary position, then go levo depression, okay? And during the depression, you need to elevate the lid to see. Then you need to switch your hand. You need to switch your hand. You cannot use the same hand on the other side, okay? Then dextroversion, then dextro elevation. Always go back to the center, then dextro depression. Then you can do the elevation and depression. Is it clear? So that is one of the most favorite ways of doing the extraocular motility in FRCS. You can do it in other ways, but as some of the candidates that have the exam previously, they said they prefer this way. So is it clear so far? You will go back at each time. I will just repeat it fast. Levo version, again to the center, levo elevation, again to the center, levo depression. Then, yes, you need to lift the lid to see the movement. Then don't forget to switch your hand and you will start on the other side. Dextroversion, then dextro elevation, then dextrodepression. Then you will do the elevation and depression for checking any pattern. Okay. Ductions only if limited versions. Ductions improved movement in paralysis and pseudo and not improved in restrictive. If the patient is having paralysis, when you are checking the movement by binocularly, the versions and the ductions, you will find ductions is better than versions. But in restrictive strabismus, it is the same. Then the saccades. Saccades is, it's not always done,
Sir,
but yes.
Sir, duction to be done on that one direction which has been limited, no, sir? Like, if I
See,
think it is abduction deficit, then I
huh,
will do that abduction movement only, no?
no. See, if, for example, if the patient is having, when you are doing the versions, the patient is having left eye limitation of abductions, or in levo version, there is a limitation, then you will close the right eye, but you need to do the whole ductions, not only the abduction. You will do abduction, adduction, elevation, depression. Okay, that is better. Do everything. Okay. For saccades, it's not always mandatory to do it, but you need to know. You usually use target in one hand and your finger in the other hand, and you will do it horizontally and vertically, half meter away from the patient. Then you will ask the patient, check the target, then see the finger, target, finger, target, finger. You will see whether the patient is having normal saccades or there is any slow saccades, floating saccades. Okay, you will do it on horizontal and vertical. Convergence, move the target slowly toward the eye. Can you see the target as 1 or 2? Look at it and tell me when it is doubled. Why to do convergence? One of the uses to differentiate between posterior INO and anterior INO. So when you are doing the test, you need to have justification why you are doing it, whether convergence or saccades. Because we don't usually do them unless I need to elicit one of the signs. Okay.
Sir, what justification do we give for doing saccades?
Saccades, for example, if the patient is having limitation in one of the eyes, for example, left limitation of abduction, and you want to know whether the patient is having left 6 cranial nerve palsy or there is a restrictive strabismus in that eye. You need to know whether it is slow floating saccades in aparitic cases or there is abrupt stop of the eye, which is going with the restrictive strabismus. To differentiate between restrictive and paralytic, that is one thing.
Okay.
And one of the important things, actually.
Yeah, thank you.
Now I will come to some of the cases, and I would like to have volunteers. Okay, so who would like to take the first case? Anyone?
Yes, please, Dr. Amar.
Okay.
Yes, like.
Okay, so check this patient and tell me what is the abnormality in extraocular motility.
Okay, in a primary position. There is a bilateral inferior oblique overaction.
Yes, exactly. How much, like approximately?
I think it's approximately +3.
Okay, okay, +3, +4. It's more of +4 because, you know, especially in the right eye. Okay, and what else?
And in while looking, there is also superior oblique. Oh, no, this is not inferior oblique at all. Something is, I think, while looking on the down on the abduction on the both eyes, right and left, there is a superior oblique, I think.
Yes, here there is superior oblique under action. This eye,
Yes.
depression, less than this eye.
Yes.
So there is limitation of depression on adduction, limitation of depression on adduction. So there is superior oblique underaction in both eyes, inferior oblique overaction in both eyes. Okay. Okay. Who else can take this case? Anybody? Any volunteer, please? It's all simple cases, don't worry. Anyone?
And I,
Dr. Tahmi, Dr. Avijit?
Yes, sir. Try.
Yeah.
Sir, in normal, okay.
In,
In lipo version, there will be superior. There will be inferior oblique overaction. So I'm just
yes,
trying to levo elevation.
yes.
Superior oblique. I can get it. Levo depression. Yeah, it's okay. Here in
Yeah,
dextro version.
there is under action, but not that much. Yes, here. Super oblique under action, but not
Yes.
much. Okay, what else?
Dextro version and left eye there will be inferior oblique overaction.
Yes,
Left
but
inferior oblique
much.
overaction.
Here also there is
And
inferior
then
oblique action, but much lesser than the left eye. Only +1 maybe,
much
+1
lesser
inferior
than the
oblique.
left eye. Yes. Yes.
Yes.
And in
Here superior
dextro
oblique is
elevation, there is again inferior oblique overaction.
yes, yes. Only
And
one thing
dextro.
here
Yes, sir.
on the
Here,
primary position.
here will be right, primary. There will be right eye hypertropia.
and
That is
and
what it says.
Exotropia.
Exotropia?
exotropia.
And
Exotropia
exotropy.
and
Yes, yes.
hypertropia. Yes. So this patient is having asymmetrical inferior oblique overaction, much more inferior oblique overaction in the right eye. Because of that, there is right hypertropia, and there is also exotropia. Actually, that is a case of consecutive exotropia. Okay, with inferior oblique overaction in both eyes, more
Okay.
in the right. Okay.
Sir, I tried to say in that way, no, what you showed.
Yeah,
Sometimes it's
yeah.
been confusing to see. So the
You
way
always
we
start with
assess, try to comment on that way. Okay, sir. Okay.
you always start with the primary position, then go for
Yeah.
dextroversion, elevation, dextro depression, then levo version, levo elevation, levo depression, and for elevation depression, if there is any pattern like significant pattern strabismus. Okay.
Yes, sir.
Okay. Anyone would take the next case?
Yes, sir, I will do.
Okay. Yeah, go ahead, please.
In the primary position, the left eye is deviated inwards. So there is a left esotropia. And the right gaze seems full. And the left gaze, there is abduction limitation of minus -4, more than -5, I think.
Yes, that
In
is
the
-5. It is not even crossing the midline.
left.
But there is one important, one important point here. When we are quantifying the limitation, we need to do deductions.
Yeah.
We cannot do the quantification in the versions, okay? But yes, you are correct. But during during versions, you will just say there is limitation in levo version in the left eye, okay?
Sir.
Then after doing deductions, you will say whether it is -4, -5, etc. Thank you so much.
Okay,
Okay,
sir.
who would like to take the next case? Dr. Asma, okay. Go ahead, please.
And the primary position, there is right hypertropia and exotropia.
Yes.
Okay. And levo dextroversion, there is right
Yes. In the extroversion, like there is again the right eye is higher than the left eye,
higher
But
than
in
left eye. Okay.
dextrodepression, there is important thing in dextrodepression.
Okay. And dextrodepression.
Yes.
In dextrodepression, there is proptosis, left eye, or what?
There is limitation of depression in the right eye. Am I right?
Limitation in depression of the right eye, yes.
Yes.
Is
So
it
here right
inferior,
eye is not going down.
superior oblique and direction?
No, 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 no. I will tell you later. Here also, eye is not going down. Here also, eye is not going down. Am I right?
Yes.
Yes,
So
sir.
in all the depression, whether dextrodepression, levodepression, or pure depression, the right eye is not going down. Here, actually, that patient is having inferior rectus injury. And because of that, the eye is going up, it's not going down. So the depression is affected in all cases. Okay?
Fragment rectus, that's
Inferior rectus, yes. Right inferior rectus. Right inferior rectus is affected. Because of that, the dextro depression and levo depression is affected. If it is problem in the obliques, you will usually have the problem only on adduction, but on abduction, it will be normal. Okay?
Sir, if you are saying inferior rectus injury.
Inferior rectus injury, yes, in the right eye. Because of that, the right eye is going up because inferior rectus is not working, and also the depression is affected. It is not working well in the right eye.
Okay.
Okay. So the patient is having right hypertropia and exotropia. Okay.
So
Who would like to take? Yes.
injury
Yes.
means what type? That's whether it is policy or restriction. What in which part we can
Injury,
consider?
injury like the muscle is cut. It is not in that place, muscle.
Oh, cut. Okay.
Yeah, like lost muscle.
Okay. Okay. Got it. Got it.
Yes.
It's a new thing to me.
Yeah,
Injury.
yeah. Like in traumatic cases, you might have that. Okay, who would like to take the next case?
I'll do it, Dr. Amar.
Okay. So, yeah, please comment.
Okay. So, in primary position, there is approximately 15 prism diopters of right exotropia
Okay.
appears to be. And in dextro version appears, there is slight limitation of left adduction. In dextro elevation, again, there is a limitation of left dextro elevation more than the right. Even right is not elevating properly. Dextro depression is normal. And in levo version, there is a limitation in of right. Actually, it's normal. And
Yeah,
levo elevation. In
Yes.
levo elevation, there is limitation of elevation, right more than left. And
No,
the levo depression is normal.
Dr. Tehmina, here there is actually overaction. Can you see here the inferior limbus?
Yes.
The distance between the inferior limbus and the lid, and here.
Yes.
Here it is
Yes.
more. That is more of inferior oblique overaction actually, but not much. Maybe plus
Right.
one. Okay.
Right.
Yeah. Here also you can see something here, and here. There is V pattern, small V pattern. You can see here more divergence.
Right. Yes.
Than here.
Yes.
Here it is
Yes.
more. Okay.
V pattern exotropia.
Yes. Yes. Exactly. Thank you. Okay. Who would like to take the next case? Anyone?
Yes, I will,
Yes, sir.
sir.
Okay. Dr. Faiza?
Yes, sir.
Yes. Go ahead, please. One of the gazes actually is missed, so I'm sorry. But you
Okay.
can go ahead with the.
Okay. So in the primary position, the child is ortho.
Okay.
Okay, and in the dextro version, there is in superior oblique overaction.
We don't say supraoblique overaction. We say
Okay, so
another.
there's in the right eye there is dextro. In dextro version, there is the left eye is basically going down.
Yes, we say downshooting of the left eye.
Okay, down shooting, right, sir. And
Yes,
in
here
the
it is okay. Here it is okay.
yes, in the levo version, it is okay.
Yes, and here.
And there is elevation defect in the left eye.
Yes. So what is the diagnosis?
Is this
Here there is also a limitation of elevation on adduction in the left eye. Okay.
okay? Is this
Brown?
Yes, that is a
Brown.
Brown syndrome
Brown.
in the left eye. Okay.
Okay, sir.
So in Brown syndrome, the hallmark is limitation of elevation on adduction. I'm sorry because the picture is not here, but here you can see the downshoot.
Okay.
Eyes in reaching the midline. So the patient is having limitation of elevation on adduction in the left eye, limitation of elevation on the left eye, but on a lesser extent, and near normal elevation on abduction. Near normal elevation on abduction in the left eye. So that is left eye Brown syndrome. And to confirm it, what we should do to confirm that it is Brown, it's not something else?
FTT will do, sir.
Yes. If FDT is positive, so that is, so this is Brown. If it is
yes.
negative, then there is other differential diagnosis. Okay, it
Yes.
should be positive. Okay, we have more cases. Who would like to take the second case? Next case.
Me, sir.
Okay, Dr. Avijit, go ahead, please. Here it is simple, not all the gazes, only primary right, left gaze.
Yeah, in primary, there will be a right eye exo around
Yeah.
almost at the limbus, more than 30 degree or 60 prism diopter, exo and slight hypertropia.
Yes.
Okay. And in right gauge, it's normal.
Okay.
Yeah, it's normal. Okay.
Yes.
In the
Yes.
left gauge, there is limitation of left is right adduction. So
Yes. And there is one more thing, if you can
uh,
figure it out from the picture.
there is shortening of the palpebral fissure.
Yes.
Yeah,
Which indicates what?
palpebral aperture.
Which indicates what?
It's retraction syndrome.
Yes, it indicates globe retraction. There is globe retraction on adduction. Hello, Dr.
Globe
Avijit?
retraction on attempted adduction.
Yes.
Yes, sir.
Yes. So here, the light reflects actually in the midway between the pupil and the limbus. So it is approximately around 60 prism diopter exotropia with hyperdeviation in the right eye. In right gaze, normal dextro version. In left gaze, levo version. Here, normal in the left eye, but in the right eye, there is limitation of adduction with narrowing of the palpebral fissure and globe retraction. So that is a case of what type of Duane, Dr. Avijit?
Type 2 Duane restriction. Type 2.
Yes, exactly. Exotropic Duane, type 2. Okay. Who will take the next case?
I'll take, sir.
Okay, Dr. Rimia. Yeah, go ahead, please.
In the primary position, the right eye is exotropic and slightly hyper.
Okay.
And on right gaze, there is narrowing of the, there is a mild adduction limitation. with the palpebral fissure narrowing. And in the left gaze, there is a adduction limitation in the right eye.
Yes.
And that eye is the palpebral fissure is almost, compared to the primary position, it's almost means the same.
Yeah, palpebral fissure here changes is not that much actually. So yeah, it's almost the same in all gazes. So what it could be, the diagnosis?
Yeah, there is adduction and bilateral. There is adduction limitation in the right eye and adduction limitation in the left eye.
No, left eye. Okay, left eye adduction.
Left eye is right eye adduction limitation. Left eye eversion, there is a left eye is not adducting, but there is an upshoot, no? In the right eye. Okay. Sorry. So left eye.
Left eye is the normal eye. The problem in the right eye only.
Okay.
So here we have limitation of depression in the right eye, limitation of elevation in the right eye, limitation of adduction in the right eye.
So third nerve
what it could
palsy.
be?
Yes, it's a right eye third nerve palsy, can we say?
Yes. That is right eye third nerve palsy, and it is complete, but there is no ptosis. And for this case, I did LR to MR
आप बुला लो सीधे मैं पे चले गए
to correct the deviation. Okay,
मेरा
we have
माइक बंद कर दो
Sorry,
माइक बंद कर
sir. You said complete third nerve palsy. How was complete? How is it complete? There's no ptosis.
It is, yes, I got your point. If ptosis is not present, then that is incomplete. But I mean, like the limitation of adduction, elevation, and depression is -4. But yeah, that is right. You are correct. We say complete third nerve only if there is also complete ptosis. Exactly.
So in case there is no adduction limitation in the left eye, right? So I was. There is no.
Yes, it is normal, but I understand. Here,
I felt that there is.
it looks like there is limitation, but actually there is no.
Okay.
Thank you. Okay, who would like to take the next case?
Sir, I am taking the next.
Okay, go ahead, please.
In a primary position, there is a right hypertropia. On the right gaze, the hypertropia is increasing along. On a left gaze, it's it's not increasing. And there is, and on a levo depression, there are restrictions on the downward movement. And in the depression, right eye is not going down, and not even a depressions, right eye is not going down in all the gazes. And even the right eye is not moving toward the lateral side. The restrictions, and there is a hypertropia over there. On the dextro elevation, the left eye is not going up, like on the dextro elevation.
Okay. Here that picture is wrong. I am sorry. That is not the elevation. Okay.
Yes.
Okay. So here in the primary position, we have right hypertropia.
Yes.
Large angle, mostly more than 60. And we have esotropia as well. Esotropia,
yes, we have esotropia.
Here, there is inferior oblique overaction. Yes. And inferior oblique overaction and superior oblique underaction.
Yes.
Okay. And here, the right eye is not going down. Eye is not going down. Actually, this patient is having right superior
oblique palsy.
But it is like since early childhood, so he developed also superior rectus restriction. Because of that, the eye is not going down, and we are having a very large hyperdeviation.
Hypertropia. Okay,
Yes.
hypertropia.
So here we have like superior oblique palsy plus a restrictive component of the superior rectus restriction plus superior oblique and or superior oblique palsy in the right eye.
Okay.
Okay. Okay.
Yes,
Who
sir,
would like to
sir,
take? Yes.
sir. In the extroversion,
Mhm.
the right gaze, the lateral
Mhm.
rectus action is totally gone because of the restriction, or
See here again, when we are checking the limitation, we need to close this eye to make sure. Actually, when I close the left eye, the eye is going out normally. There is no limitation of abduction. Maybe in the picture it is showing, but on the examination there was no limitation of abduction. Okay.
Sir,
and in,
not doubt. Usually in the superior oblique palsy, the hypertropia should increase in the right gaze. If it is a right superior oblique palsy, it should increase in the left gaze, right? So here it is actually more right gaze, no?
The thing here, we have two components, the paralytic component, the superior oblique palsy, and the restrictive component of the superior rectus. So many of the laws that we usually can apply on patient with paralytic strabismus, we cannot use it here because we have two components, paralytic and restrictive component. So in such cases, all the three-step test will not work very well because you have a restrictive component. Okay.
But the lateral gaze superior rectus elevation looks actually normal.
Yes, superior rectus actually it is working more than normal. It is restricted. You know, it is pulling the eye upward, and it's not letting the eye going downward. It is very powerful.
Okay.
You got yes. Okay.
sir, any relation of that superior oblique palsy with superior rectus overaction?
No, superior rectus restriction actually. When I took the patient to OT, I did FDT. He had a very restricted superior rectus recession. So because of the very large angle, actually I did inferior oblique anteriorization plus superior rectus recession. Okay.
So it's like
Sir,
a secondary, secondary
fracture.
Secondary
Yes.
to
Yes. Secondary to the paralysis.
paralysis, long time paralysis.
Yes, exactly.
okay.
So can we say it's a congenital? That's why it's like we have a superior rectus palsy along with this.
No, superior rectus is not paralytic. It is
Sorry,
restricted.
restrictive. Yeah, it's restricted due to the congenital SO4 palsy.
In long-standing cases, whether it is congenital or acquired, but for a very long time, that will happen with time. Okay.
Okay.
Okay. Who would like to take the next case? Anyone, please? It is a nice case.
I will take it, sir.
Okay. It is a video actually. So please see the video and tell me.
जल्दी लेके आ यार उठाया क्यों है किसने उठाया वजह बगैर पूछे चुप के ले आओ फाड़ के ले आओ जल्दी
Can you comment on the video, please?
Yeah, in the right eye, during adduction, there is narrowing of the palpable fissure height along with upshoot, and there is limited abduction.
Yes.
As the eye adducts, there is narrowing and upshoot, and abduction is limited.
Okay, so what is the diagnosis?
It can be type 1 Duven's.
No, type 1.
Type 3.
Yes, mostly type 3 because there is limitation of adduction and limitation of abduction with exotropia and upshoot, severe upshoot. Okay.
Yes, doctor.
Okay.
Sir, please play the video again, sir. Just one minute, sir.
Yes, please, sir.
Yeah.
Yeah.
Yeah. Okay, here in the left gaze, there is severe upshoot with globe
Okay.
retraction
Okay.
and limitation of abduction in the right eye as well. Okay.
Okay. Okay, sir. Okay, sir. Now,
So, anyone can guess what operation we have done for this patient? She had exotropia with upshoot.
So lateral rectus recession with Y-plasty, plus minus Y-plasty.
Yes, definitely. For the exo, we have done lateral rectus recession and we did Y splitting to correct the upshoot. Okay, Y splitting. Okay. Anyone can take this small video?
Yes, I'll try.
Okay. It is simple. So here I'm doing the cover test over the left eye, uncover, then cover, uncover, cover, uncover. So what do you say? What do you see, Dr. Rimia?
Yes, when you cover the left eye, the means undercover eye, when you take the cover, the left eye slowly comes down to take up the fix.
Yes.
When you cover the, it's, yes, it slowly comes down to takes up the fixation. And when you cover
Yes.
the right eye, I cannot see the movement actually, but usually there will be some movement. It's a dissociated vertical deviation.
Yes. Even here also, there is again right.
Movement.
It is vertical division, but much lesser than the left eye.
Yes.
So the patient is having bilateral DVD more in the left eye.
Yes.
See here the left eye, large. Here, small DVD. So when you are having a patient, his eyes, both of them will come from up to down. So this is not hypertropia. This is DVD.
Yes.
Okay. Here again, Dr. Rimia, can you see this, please?
I will try. Yes, the left eye is coming down. I'm covering the right eye and taking.
Here I'm doing prolonged cover test. You need to do prolonged cover test. Otherwise, you'll not elicit the DVD.
Yes,
so that patient is having.
Yes, bilateral DVD.
Yes, also bilateral DVD, but almost the same degree.
Yeah.
Maybe the left eye is
yes,
yeah,
it's
I
coming.
think. Yeah. Okay. Okay. Thank you so much for your
sir,
interaction.
you said that in DVD both eye will be like one eye, both eye will be hypertropic like that way, or what do you say?
If it is bilateral, if it is bilateral. If it is bilateral DVD, and it is almost always bilateral, but sometimes it is asymmetrical, especially if there is one amblyoptic eye, then in that eye DVD will be more. Okay. One more thing, if it is unilateral DVD, then when you are covering the other eye, there is no compensatory movement. The other eye will not come from down to up. If it is hypertropia, then the other eye will come from down to up. Am I right?
Yes, sir. Yes, sir. Okay.
Because according to hearing law, but in DVD,
Yes,
it is not obeying hearing law. Because of that, you know, both eyes will not move together. Because of that, the name dissociated, it is dissociating. Okay.
Yes, sir. Okay, okay.
Okay, coming to the last part of the presentation, I will just go fast through the nystagmus. So definition, it is a regular, rhythmic, repetitive to and fro movements of the eyes. Movement which are not regular and rhythmic are called nystagmoid movements. So nystagmus usually you will have rhythmic, regular, repetitive movements. If you are having haphazard movement, the movement is not the same, then that is more of nystagmoid movements. That nystagmus might be horizontal, vertical, rotatory or torsional or mixed. Okay. Here, for a patient with nystagmus in FRCS exam, they are not expecting much from the candidate, but you need to know the basics of nystagmus evaluation. So first of all, you need to give yourself time. You cannot comment after 2 or 3 seconds. You need to observe for at least 10, 15 seconds. Take your time, okay? Then you need to describe what are you seeing. So firstly, you need to know the type, whether it is pendular nystagmus or jerk nystagmus. That is the first point. Then you need to know whether it is unilateral nystagmus or bilateral nystagmus. Then you need to know if it is jerk nystagmus, then whether it is right jerk nystagmus, left jerk nystagmus, if it is horizontal, if it is vertical, if it is torsional, if it is mixed. Then you need to comment about the amplitude, the frequency, and the intensity. Okay? So simply, when you are seeing a nystagmus patient, you need to give yourself time in the beginning. Then you need to figure out whether it is unilateral nystagmus or bilateral. Most of the cases will be bilateral. Then you need to figure out whether it is pendular nystagmus or jerk nystagmus. Of course, in some cases, you will have pendular nystagmus in the primary position. In side gazes, you might have jerk nystagmus. That also can happen, especially in infantile nystagmus syndrome. Okay. Then you need to comment on the amplitude, whether the excursion of the nystagmus, is it small amplitude, moderate amplitude, large amplitude, and the frequency, the number of to and fro movement 1 second. Again, we cannot quantify it exactly because you need nystagmography to know exactly the intensity and amplitude, but it is a crude method. Only you need to comment whether it is high frequency, slow frequency, medium frequency, and the intensity. Okay. I will come through some of the examples so things will be easier. So in this table, here all the types of nystagmus. I'm not going to cover it, but please refer to this table. It will make life easy. We have physiological nystagmus. We have pathological nystagmus. In the pathological nystagmus, we have different types, whether it is due to poor vision, the sensory type, whether there is neurological problem, motor, and whether it is nystagmus associated with strabismus, miscellaneous other types, and nystagmoid conditions. Those are not nystagmus. Those are nystagmoid conditions like oculopalatal myoclonus, opsoclonus, ocular bobbing. Okay. Here we have the infantile nystagmus syndrome or the congenital motor nystagmus. It is one of the most common types of nystagmus, and it is the commonest type actually in children. So you need to know more about this because it is one of the most high yield cases that will come if you have a nystagmus case in the exam. So here the word congenital mnemonic for the characteristics of infantile nystagmus syndrome. So with convergence and eye closure, the nystagmus dampens. Those patients have no oscillopsia. They are not experiencing any oscillopsia because of the suppression. Usually there is a null zone. Gaze position does not change the horizontal direction of nystagmus. It is uniplanar and equal amplitude and frequency in each eye. It is conjugate nystagmus. Usually near acuity is good in those patients because with convergence, the nystagmus dampens and foveation time increases. So the near acuity usually is good, even though the distance acuity is not good. Inversion of optokinetic response, turning of head to achieve null point, abolish or in sleeping, and latent nystagmus occur when occluding one of the eyes, the nystagmus will increase. So those are the characteristics of congenital motor nystagmus or the infantile nystagmus syndrome. Here, other types of nystagmus, like the seesaw nystagmus, the downbeat, upbeat, convergence retraction syndrome, Bruns nystagmus, everyone with the lesions that causing that type of nystagmus. Most importantly, the downbeat nystagmus usually problem in the cervico-medullary junction or the Arnold-Chiari malformation. Okay. Also convergence retraction syndrome, dorsal midbrain syndrome, and Bruns nystagmus, the cerebellopontine angle tumors. Here are also other types of nystagmus. Here is the periodic alternating nystagmus. Let's see the video. So the patient starts with right jerk nystagmus, the fast phase toward the right side. Fast, slow, fast, slow, fast, slow. Okay. After some times, the nystagmus slows down. Then there will be reversal of the nystagmus and it will be left jerky nystagmus. Okay, that is the periodic alternating nystagmus. And to elicit such thing, you need to observe the patient for a few minutes to elicit if the patient is having pan or periodic alternating nystagmus. That is pendular nystagmus. So you can elicit that the movement in both directions with equal speed. Okay, the amplitude is equal. So that is not jerk nystagmus, that is more of pendular nystagmus. Pendular, you can have slow pendular and like this faster one. This one, upbeat nystagmus. See the jerk, it is going up, then down. Fast phase, up. Upbeat nystagmus, fast phase, up. Then the slow phase, down. Up, the fast phase up and the slow phase down. Upbeat nystagmus. Okay, who would like to take this case? That is a case of nystagmus. Anyone can comment on it, please?
I will do.
Okay, Dr. Remia. So if you have that patient in your clinic, comment on it. Take your time. You repeat the video again. Okay.
There is a jerk nystagmus with fast phase to the left in the primary,
Yes.
with this, which is decreasing in the right gaze, that is left phase turn, and increases in frequency to the left gaze or the right phase turn. So the null position is to the right gaze.
Yes, exactly. So in the beginning, the patient in the primary position is having left jerky nystagmus. That jerky nystagmus, how we can describe it?
It's a small amplitude.
Okay. And frequency?
High frequency. Moderate, moderate to high frequency.
Yes, we can say moderate frequency. It is almost null in the right null position. And in the left gaze, it is increasing. Okay. So in such patient, what can we do for them?
So we can do surgically correct to make the right gaze to the primary position, so that
yes,
we can with the phase turn can be corrected.
Yes, Kistenbaum-Anderson procedure can be done to shift the null position from the right gaze to the primary position. Am I right?
Yes, sir.
So in such patient, I will just say something in this. So in such patient, okay, when we are doing the Kistenbaum, we are dealing with this eye as an exotropic eye. So we will do left lateral rectus recession
Right rectus recession
and medial rectus
resection.
resection. And here that is the esotropy eye. So we will do medial
Left
rectus.
medial rectus recession and lateral rectus resection.
Exactly. So with that, we will shift the null position from the right gaze to the primary position. And the quantification is according to the degree of the face turn, whether it is 15 degrees, 30 degrees, 45 degrees, then we will do the numbers according to the degree of the face turn.
Yes, sir.
Okay. Who would
Sir,
like to take this?
can you
Yes.
explain it again, sir? The surgical procedure, why it is done like that way? That surgical
Yes.
procedure, sir.
Yes, I will tell you. Okay, so this patient is having left jerky nystagmus, and the nystagmus nullified in the right gaze, okay?
Yes, sir.
So null position in the right gaze. So what we need to do is to shift the null position from the right gaze to the primary position, okay?
Yes, sir. Yes, sir.
So in that case, that eye is exotropic or esotropic? It is outward, am I right?
Outer. Yes, sir. Exo.
And this one is inward. So you will
Yes,
do
sir.
lateral rectus recession, medial rectus resection,
Okay.
medial recession, lateral rectus resection. Because this patient does not have strabismus, she has only nystagmus. So you don't want to induce strabismus in this patient. So we will do balanced procedure. Recession, resection, recession, resection. So you will just shift the null point to the primary position without inducing strabismus in the patient. Okay.
So Dr. Amar, we have to describe, say, like the null position according to face turn or a gaze. So in this, there is a right gaze, so there is a null position. We have said the patient have a jerky nystagmus in primary position, which is a dumpens on right gaze, like this.
Yes,
So null
right
point
gaze,
is right.
and the patient adopt left face turn to, put the eyes on the right gaze.
Okay.
So you can describe it on either ways, I think.
Okay.
Okay. Who would like
Thank
to
you.
take the next?
I can take.
Yeah, that is interesting case. Go ahead, please. Take your time. I will repeat the video. It is a small video, actually. So we can repeat it one more time. Okay, again.
Yes, please. So basically, in primary position, there is a no nystagmus, but when there is a patient moving his eye to the left side, there is a elicited nystagmus. This, which is a jerky type or pendular type nystagmus.
Okay. So what it could be?
It's good.
It is like spot diagnosis, we can say. So here, check here. There is limitation of adduction in the right eye with left abducting nystagmus.
Yes, this is INO.
In which
This is
eye?
intranuclear ophthalmoplegia.
Which eye?
This is the right.
Yes, right, INO. Right internuclear ophthalmoplegia. There is limitation of adduction in the right eye and left abducting nystagmus in the left eye.
Left eye.
Okay. So there is problem in which part?
In the right MLF, right medial longitudinal fasciculus.
Exactly. Okay, last case in the presentation. Who would like to take it?
Sir, me.
Okay, go ahead, Dr. Avijit.
All right, get this reduced. Left gaze. It is right gaze reducer, primary
So
Up
in the
and
primary,
down.
what is it?
Uh, so in primary, there is a jerky nystagmus. Fast
Yeah,
phase, first phase towards, I think, right. I have to see the video again, sir.
yeah. See, right face toward the right or the left?
So in right case, it dampens.
Yes,
Dampens,
yes,
yeah. But in left case, yeah, it is still there.
yes. But check here, please. Is it
Yeah.
right jerk nystagmus or left jerk nystagmus?
So I'm just play it again. Yeah, it's left jerk in the left side. The jerk is in the left side. It's
Yes,
not
that
right.
is left jerk nystagmus. Okay. Can
Left.
you comment on the amplitude, frequency?
Yes, sir. It is high frequency, low amplitude. Am I right, sir? Or
Moderate amplitude, I think. And the frequency also, we can say it is moderate.
moderate?
See,
Okay.
the amplitude, it is about the excursion, like how much the eye is moving. So that is not a small amplitude, and it is not also very large, So we can label it as a moderate. And the frequency also, again, it is not low frequency, it is not high frequency. So I think moderate amplitude, moderate frequency, we can call it. It is
So
dampened.
why left jerk nystagmus?
See here, check here and see where is the fast phase. The fast phase toward the left side. Can you see it here? It is going fast to the left, then going slow to the right.
Yes.
Okay?
Yes.
Yes, sir. Left side. First person left side.
Yes. So here, left jerk nystagmus, moderate amplitude, moderate frequency, decreasing in the right gaze or the left face turn, and increasing in the left face turn. Yes, am I right? It is increasing in
Yes, sir.
frequency.
Yes, sir.
Yes.
Yeah, here I did the other head positions just to see what is happening. So it is uniplanar here. It is not changing the direction when am I changing the head position. It is all the time. It is horizontal nystagmus. It's not going vertical or torsional or anything else. Okay, and it is conjugate nystagmus as well. So both eyes are moving together, same frequency, same amplitude, same direction. Okay.
Sir, are you doing the same thing corresponds to the eye movement in different gauge?
No, here I'm just trying to figure out where is the null point, and I am figuring out if there is any multiplanar nystagmus. For example, in up gaze, down gaze, the nystagmus is changing in direction from horizontal to vertical or anything like that. So I'm doing the different positions just to make sure if there is any difference, if it is conjugate nystagmus everywhere in all positions, or there is any changes. Okay.
That means I want to know, sir, that one point in nystagmus examination, like the eye movement, one point. So you are doing that eye movement, no, sir, in different gauge?
Yes. So in nystagmus patient, you usually comment on the primary position in the beginning. After that, you comment on the right gaze, left gaze, up gaze, down gaze, what is happening to the nystagmus to
And
know
we'll
if
ask
there
the
is any null
patient to fix the
point.
target in distance, no, and we can do the way what you have done.
Yes, whether at distance or at near, you can do it, I think, both ways. Okay?
Okay.
Okay, thank you so much. Is there any doubts before finishing the class?
Sir,
No, Dr. Amar, you have cleared the doubts about the nystagmus. Thank you so much.
You are welcome.
sir,
Thank you.
what is the meaning of that? What is the significance of horizontal jerk in nystagmus? If it has been asked, what is the significance or what is? I think I have forgotten. In one exam, uh, examiner asked what it signifies.
So
Horizontal jerk.
basically, it tells you the where the lesion is. There is a horizontal jerky nystagmus and pendular. Say different lesion in the brain, they gives you this horizontal and jerky.
See, for jerky pendular, it can happen in any type of nystagmus. Usually in nystagmus, you need to answer those questions. So if you have, for example, a child or a patient with nystagmus, you need to know whether it is congenital, it happened before 6 months of age or after 6 months of age. Okay. So if it happened after 6 months, if it is acquired nystagmus, then this is alarming sign that there might be a neurological problem. That is one point. Second point, the direction of nystagmus, whether it is horizontal or vertical. So if it is horizontal and it is since birth, then that is one of the benign forms of nystagmus. It might be congenital motor nystagmus. But if it is vertical, then again, that alarms you that there might be a neurological cause for the nystagmus. Okay. Then the other thing, whether it is conjugate or disconjugate, and whether it is unilateral or bilateral. In conjugate nystagmus, that is again a benign sign. If it is disconjugate, then that is alarming sign. If it is unilateral and there is no cause of, loss of vision in that eye, then again, that is an alarming sign. So why those alarming signs are important? Because you will need to do neuroimaging to rule out if there is any organic lesion that is causing the nystagmus, whether there is any lesion in the midbrain, in the cervicomedullary junction, in the, in any part of the brain.
Okay. So
Okay.
vertical, you said there might be alarming sign. Horizontal also there might be alarming, no sir? Alarming or
Horizontal
benign?
acquired, for example, horizontal acquired presence of
Acquired.
osteopsy. A patient is, feeling that everything is moving around him. So oscillopsia is one of the signs that is an acquired nystagmus that happened after, the visual development. There is no suppression. So that is again alarming sign that it might be caused by a neurological problem. But I will say it once again, usually what I have seen from the previous candidate experiences, usually examiners will not go very deep in nystagmus patients because they know, it is a really complicated cases even for strabismologist and neuro-ophthalmologist. So you need to know the basic things. Jerk, pendular, horizontal, vertical, amplitude, frequency, is it conjugate, bilateral or not, if there is any null point, And also one more important point I forgot to mention, you need to check the patient. For example, patient with albinism, so that is a clear sign that patient is having sensory nystagmus. So or patient who is, for example, wearing aphakic glasses. So he had already congenital cataract surgery in both eyes. So such things will help you in eliciting what is the cause of the nystagmus. Okay. Aniridia as well, microphthalmia, all these things will help you to elicit what is the cause of nystagmus.
Sir, please tell about Anderson also for the sake of others, Anderson procedure, because that you are the most important, no? Can rest. Yes.
I'm sorry, Dr. Remy, I didn't hear the question. Can you repeat it, please?
No, sir, nystagmus surgeries, you explained about a Kestenbaum surgery, right? So I think
Yes.
Anderson surgery also is more important.
Yes.
Yeah.
Yes. In Kestenbaum procedure, we usually do recess, resect, recess, resect. In Anderson, we only do recession. Okay. Yes, we only do recession, whether 2 muscle or 4 muscle recession. And we do those procedures if the patient is having null point in one of the, whether face turn, right face turn, left face turn, even for chin up, chin down. Also, we can do recession, resection for the muscles to shift the null point to the primary position.
Sir, for the example what you showed, na, that right gauge null point, you explain the custom bomb. So if you explain Anderson in that case, what we should do?
So for Anderson, you will do left lateral rectus recession and sorry, right lateral rectus recession and left medial rectus recession only.
Okay.
So you will do recess again. So you will do a balanced procedure, and the patient will not have strabismus, induced strabismus after the surgery.
Okay, sir. Sir, in strabismus, the hypertropia case you noted down in your page. So you noted all the prism diopters in all the point like gauge and tilt and everything. That means you measured all the deviations with prism.
Yes, yes, definitely. You need to measure them. Then only you will get to know the hyperdeviation is more in the right gaze, left gaze, right tilt, left tilt, you know, up gaze, down gaze. So you need to measure the deviation in all the position of gazes.
Sir, in exam we have to do all these things. I'm
No,
scared,
no,
sir.
no. I will tell you my real experience in my exam. In the strabismus clinical station, I had a patient with exotropia. Okay. So what I have done, the examiner told me check the extraocular motility. So I told him, can I check the cover test in the beginning? He said, okay, go ahead. Then I asked him what is the visual acuity for the patient. He told me patient is seeing 6/6 in both eyes with glasses. So I started with cover test, uncover test in both eyes. Then I did alternate cover test. Patient had exotropia. Then I told him I would like to measure the angle of deviation. So he gave me prism actually, and I did the measurement of the exotropia at near and at distance only in the primary position. Then, because of the time constraints, I did the extraocular motility. The patient also had inferior oblique overaction in both eyes. And then he just asked me 2 or 3 questions about what are you going to do for this patient to treat the exotropia. I told him, first of all, I need to give the refractive correction. Secondly, if there is any amblyopia on one of the eyes, I need to treat the amblyopia. Then I will do surgery, whether I will do bilateral right rectus recession or unilateral lateral rectus recession and medial rectus resection to treat the exotropia, and inferior oblique weakening procedure, myectomy or recession to treat the inferior oblique overaction. So usually the examiner will not let you do the measurement of strabismus in all cases because time is really very short in clinical station in FRCS Glasgow. You have only 12 minutes in each station and you need at least to finish 2 cases. So don't worry, the examiner will guide you, but you need to say them in the beginning. That is the point that
And
I want to stress. Just in the beginning, ask about the visual acuity, check the glasses of the patient, then tell this. I would like to do cover, uncover, alternate prism cover test for the patient at near in the primary position, at distance in primary position, right gaze, left gaze, up gaze, down gaze. Then you proceed with the primary position. Usually the examiner will stop you after that. He will not let you continue to save the time.
okay. And you examined with glass, na, sir?
Yes, with glasses, and the examiner told me, would you like to examine the patient without glasses? When I removed the glasses, the patient could not see properly. He was high myopic. Then I told the examiner, patient cannot fixate properly because of the decreased vision. So I did only Hirschberg without glasses, and that was enough.
Okay. Sir, one practical question that initially we give refractive correction, and then we say previously also discussed that amblyopia therapy should be given along with, or we should give the refractive correction first, followed by the amblyopia correction, and followed by that, if the strabismus not improved, then we'll go for surgery.
See, it depends if the patient will come back to you, if the patient is near to you, if the patient is compliant or not. So all these factors actually play an important, role in your decision. So in typical cases, you need to give the refractive correction first. And then if there is still amblyopia in one of the eyes, then in the second visit, you'll start doing patching therapy. But again, if the patient, for example, is living far away, or you are afraid that he might not come on his regular follow-up visits, then you can start both refractive correction and doing the patching therapy. Okay. After maximizing the amblyopia treatment, then you will go for the strabismus surgery, or when there is a failure of amblyopia treatment and still squint is there, then you can go for the squint operation.
Sir, any timeline for saying it is a failure of amblyopia therapy? Any fixed timeline, like 6 months or?
Usually 6 months to 1 year, but putting in your mind that the patient is compliant and he is really doing the patching every single day for the amount of hours you are giving him. So if you are 100% sure that the patient is compliant, every single day they are doing the patching for the child or the patient, and there is no improvement within 6 months to 1 year, then you can say there is a failure of amblyopia therapy and you can go for the strabismus surgery for cosmesis.
Okay, sir.
Okay.
Doctor,
Yes.
when they ask us to do the extraocular motility examination, at the end of examination, do we have to check for vergence, like near point of convergence and such?
You don't need to do it. I think, you see, you need to know that the elements of extraocular motility, you need to do vergence in the beginning, then ductions only if there is any limitation, then vergence. But when you are doing vergence, you need also to have a justification for that, I want to do vergence to check for this or that, For example, patient with convergence insufficiency exotropia, and you need to know whether the patient is having abnormal convergence. Or that example that I gave in the presentation, patient with INO, and you need to know whether it is anterior or posterior to differentiate. Okay.
Okay.
Yeah. Usually if the examiner asked you for extraocular motility and he don't want you to do to do cover test, then there is abnormal extraocular motility, whether there is sixth nerve palsy, third nerve palsy, Duane syndrome, Brown syndrome, monocular elevation deficit, something like that.
Okay.
Sir, one partial statement I want to confirm that in INO, there are statements that are controversial in Kansky and American Academy. So I think, can you show that slide you have already mentioned? I have forgotten. For
Yes,
anterior, I think you have written lost.
about it. Yeah. Posterior INO, it is lost convergence. Anterior INO, it is intact. And I know, yes, your point is totally right. There is contradiction about this in different references. I agree with you.
So posterior, I know it will be lost.
Yes, yes. According to my reference, yes.
Okay. Posterior lost. Okay.
Basically, till in typical INO, the convergence will not be lost. Just full stop there.
Yes.
In typical INO, the convergence will not be lost. And do not go anywhere. Anterior, posterior, nothing. If the examiner asks and wants to go to detail, then go there. Do not go to any controversial area in exam.
Yes, yes, yes. Totally agree, Dr. Kaushik. Yes.
Okay. Typical INO convergence will not be lost.
Yes.
Okay.
I think the convergence center is slightly up. It's not in the means that's why in typical INO the convergence is intact.
Yeah.
Yes. Okay. Any more doubts?
Dr. Ahmed, one more question. Like in a horizontal nystagmus, we say the fast phase to the right or left, but in a pendular nystagmus, we don't need to mention that.
Yes,
Because there's
it is
no
the
any fast phase, there's a slow phase, both sides.
same velocity and on both sides.
Yes, same on both sides.
Yes.
Sir, pendular, the etiology of pendular, I think, as as per my short knowledge, it's a limited etiology I know as far. Like the sensory, the congenital sensory nystagmus,
See,
or yeah.
only pendular or jerk, you cannot reach the diagnosis. It is you know it is only one information, because you might have congenital motor nystagmus with pendular nystagmus in the primary position, but when the patient is looking at right or left, then it became jerk nystagmus. Okay, but as you mentioned, pendular nystagmus is more in sensory type nystagmus, patient with congenital cataract, with aniridia, with albinism, but also you can find those patients with jerk nystagmus. So with only the type of nystagmus, whether it is pendular or jerk, you cannot reach diagnosis with only this information. You need other things.
Okay, sir.
Okay. Okay, thank you so much.
Thank you so much, Dr. Ahmed.
Thank you, sir. Thank you
Dr.
very
Ahmed. This
much.
was very helpful. Thank you.
Thank you so much, Dr.
Very much, sir. Thank you very much.
Thank you, sir.
Thank you for your time and your